and their opinion, which in my opinion is contempt prior to investigation, because remember, I had that same opinion. Their opinion is that this is not a valid treatment. In other words, if you go to treatment 3, 4, 5 times and you fail your 12-step program, it must have been because you didn't work a good program. You're what the well, I won't get into that. But at any rate, that is what is happening. So look at this overdose death rate. This is the overdose death rate following 1 month of sober inpatient treatment for an opioid addict. So you take somebody shooting 1.5 grams of heroin a day who wants to get off of it. She or he comes into the treatment center and they detox them, which by the way is a horrible mistake. But they detox them using a short course of Suboxone, and then, provided the person can sit still long enough, they put them in groups for the next 3 weeks. And they teach them about the 12 steps and recovery and all that stuff. And then they release them out into the wild. Now, short-term detox from opioids has a 95% relapse rate. What is short-term detox? It's anything less than 3 months. So when you release this drug addict after 1 month, he experiences reentry phenomena. When the level of emotional stress is up to here, no problem. I can deal with it by means of willpower. Level of emotional stress is up to here, I'm fine. Level of emotional stress is up to here, oh no, I'm treading water. Level of emotional stress gets up here, I'm going to pick up because I know what relieves that. And when they pick up, even if they dose themselves down, that's when they OD. What's the peak time to OD following release from a sobriety-based recovery center? 2 weeks. What is the 1 year mortality for opiate addicts released from a sobriety-based treatment center? 29.1%. That's almost 1 in 3. This stuff drives me nuts. I'm sorry. Medication assisted, here's another ignorance attribution, okay? Medication assisted therapy is seen as substituting one addictive drug for another. The best example of that is Woody Allen's Annie Hall. And they have this scene where they flash back to the past when Woody's in 2nd grade. And one kid gets up and he says, I'm Anthony Scapolio, and I grew up to be a plumber and have 3 wives. And the other kid gets up and says, I'm Jonathan, and I'm a heroin addict, but I'm better now, and I'm a methadone addict. You know, that's the way society at large thinks about this. But how do we in addiction medicine think about it? Look, there's a difference between addiction and dependence, all right? Now, a drug addict who's practicing is dependent upon heroin, all right? If they don't have heroin, they go into withdrawal. But in addition to that, they are also practicing drug addict behaviors: lying, cheating, stealing, manipulating, committing criminal acts to get the medication, all right? Or the heroin. Now, someone on methadone is dependent on methadone. If they go off it, they'll go into withdrawal, but they are not lying, cheating, stealing, manipulating, committing criminal acts to get heroin, okay? They are in recovery. And when you give the appropriate dose of methadone or buprenorphine to an addict, as long as they're not doing other drugs, which admittedly is a big problem, but as long as they're not doing other drugs, it just makes them feel normal. They don't get high from it. Another common misconception, NIMBY, not in my backyard. You want to have a methadone clinic? Not in my backyard. So you get the legion of people who never come out of their houses come out in droves when they find out that you're going to put a methadone clinic in the neighborhood. Also, crime rates around methadone clinics are actually lower than they are other parts of the city. These people are interested in getting better. And, you know, just so you understand it from the street level, you don't excrete where you eat, okay? So you don't commit a crime on the grounds of the methadone clinic, otherwise you're going to be deprived of methadone, okay? So most of these perceptions about methadone arise from ignorance. Methadone or buprenorphine, what's the right choice? The choice of treatment should be made on the basis of individual patient evaluation. Generally speaking, methadone's preferred for patients who don't travel. They have a high tolerance to opiates and they need close clinical follow-up. Buprenorphine is safer to use. It can be used in a primary care setting and it's widely available. The typical starting dose of methadone is 20 or 30 milligrams with 10 milligram escalation every 24 hours up to 50 or 60 milligram dose, and then you wait for a while. Why do you wait? Well, that's in this graph. Steady state simulation of methadone maintenance. This is escalating methadone peak and trough several days out without a change in dose. Okay, so are methadone clinics killing patients with methadone? No. Where's that happening? That's happening because chronic pain patients or other patients being prescribed methadone by people who are not as familiar with it, and they go up on the dose too fast, and when you do that, you get respiratory depression and death. This has been known about methadone, or dolafine as it was called, since it was synthesized in 1937 in Nazi Germany. Buprenorphine can be titrated over the first 24 hours. The maximum dose is 24 milligrams. If you don't walk away from this talk with anything, walk away with this. Never, ever, ever give opioids with benzodiazepines. Opioids plus benzodiazepines equal death. You know, if you want to do that in the hospital where the person is being observed and stuff like that, I understand that. That's fine. But don't send a patient home with a boatload of narcotics and a bunch of Xanax. In methadone, every single overdose death that we have had in methadone care has always involved Xanax. It has never not involved Xanax. This is the drug I hate the most. This is buprenorphine. Buprenorphine is a partial agonist, and it has a ceiling effect for its opioid effect. Beyond a certain dose, you don't get any more effect. That's what makes it so safe to use in outpatient practice. It's not as potent as methadone, though. So if you have somebody with a really high tolerance to narcotics, say they're shooting 2 grams of heroin or more in 24 hours, then you're probably going to need methadone because they're not going to be happy with maximum dose buprenorphine. We're going to go through 3 clinical scenarios pretty rapidly: the pregnant patient, the trauma patient, and the so-called problem patient. Really, we're talking about pregnancy mainly from the standpoint of the fetus. Neonatal abstinence syndrome is a drug withdrawal syndrome in newborns caused by the mother's substance use during pregnancy. Neonatal abstinence syndrome is exposure to illicit or prescription drugs that circulate in the mother's bloodstream, cross the placenta. Both mother and child become physically dependent. Once the child is born, they go into withdrawal. The clinical presentation of the child involves gastrointestinal dysfunction, autonomic signs, and neurologic excitability, up to and including seizures. So frequently they got to be observed in the NICU, and they also have to have either morphine or phenobarbital administered. there's an increasing incidence of this. There's a 4-fold increase in the admissions to the NICU for neonatal abstinence syndrome between 2004 and 2013. We went from 7 cases per 1,000 up to 27 cases per 1,000. Length of stay during this period went from 13 to 19 days, and fully 74% of infants required morphine treatment. In 1998, the NIH consensus panel reaffirmed methadone as the standard of care. That's the gold standard. Methadone has a proven track record with respect to reducing obstetrical and fetal complications, in utero growth retardation, and neonatal morbidity and mortality. Methadone normalized, oh, this is really important. When you have a young woman that comes into methadone treatment and she hasn't been having menstrual periods, you know, that's first of all, that's extremely common. Why is it common? Because you know, when you're going up and down like this, shooting dope every 4 hours, it puts your endocrine system out of whack. And when you come into methadone, methadone normalizes your endocrine system. The young woman starts having periods again, and if she is sexually active, she can become pregnant. So it's really important to counsel those patients when they come into treatment. This is particularly important. There was apparently a paper in an OB-GYN journal, I think they call it the Green Journal, talking about taking mothers who are on methadone or buprenorphine and tapering or detoxing them during pregnancy. Don't do that. That is putting the mother or the fetus at risk of miscarriage, premature delivery, of fetal death. If you have to do a so-called medically supervised withdrawal, and I would never do that unless it was absolutely, you know, necessary to do that. But if you have to do that, do it during the 2nd trimester, because you're less likely to pose a risk to the child. The other thing you have to remember is that the doses of methadone and buprenorphine are going to need to be increased during the 2nd and 3rd trimester. As the woman's plasma volume rises with pregnancy, hepatic and renal elimination of the drug increases. So you need to increase the drug. And you just monitor them for signs and symptoms of withdrawal. The dosage of methadone or buprenorphine doesn't really correlate too well with neonatal abstinence syndrome. That's what, at any rate, there's no evidence of long-term adverse outcomes for children born to mothers receiving methadone maintenance. And we've been doing this since the 70s. This is not new. Methadone or buprenorphine needs to be continued into the postpartum portion of the patient's care because you don't want them to relapse. Also, you're probably going to need to decrease the dose of methadone or buprenorphine. Now, everybody knows what too much methadone looks like. They're nodding off. But the thing that they miss is too much energy. What you need to understand is that if I went around and I injected each of you with 10 milligrams of IV morphine, you'd probably go to sleep. If I injected an addict with 10 milligrams of morphine, he'd get up and clean his house. Opioids give opiate addicts energy. They process these drugs differently. HIV is the only contraindication to breastfeeding. Hepatitis C is not a contraindication to breastfeeding. It is strongly recommended that the mother of the child breastfeed, because breastfeeding is great in terms of passive immunity and the bonding of the mother and child. And the amounts of buprenorphine or methadone are absolutely minuscule. Also, buprenorphine is a sublingual preparation. It is not absorbed orally. So there's nothing to worry about. The Maternal Opioid Treatment Human Experimental Research, you know, I think that they chose that name just so they could say it was the mother study. But at any rate, it's a multi-center head-to-head double-blind study looking at methadone versus buprenorphine. What they found was that a lot of things that were probably obvious. First of all, that more people stopped buprenorphine than they did methadone. Why? Because they couldn't get a high enough dose of buprenorphine to relieve their symptoms. Infants born to patients treated with buprenorphine used less morphine, had a shorter length of stay, and had shorter duration of neonatal abstinence syndrome. That's probably because buprenorphine is a partial agonist instead of a full agonist. 71% of those who stopped buprenorphine did so because they were dissatisfied with it. There's no significant difference between the two drugs with respect to percentage of neonates requiring treatment, scores, head circumference, etc. Buprenorphine exposed neonates required 89% less, etc., etc. Buprenorphine should be considered first line in those patients who are not highly dependent on opiates because it decreases the amount of morphine and the length of stay. The trauma patient. So you're in the emergency room, patient presents with multiple trauma status post-MVA, is currently taking 120 milligrams daily of methadone. What do you do? Number one, continue the methadone. Number two, give short-acting narcotics as you normally would on top of the methadone. Why don't you increase the methadone to control pain? Because it has a very long half-life. It's not going to kick in. This patient needs pain relief right now. So you leave the dose alone and you medicate with short-acting opiates, keeping in mind that this patient's tolerance is probably going to be pretty high. Okay, let's take the same patient, only this time they're on buprenorphine. They're taking 24 milligrams of buprenorphine. Well, that's entirely different. At that point, you've got to stop the buprenorphine, and then you have to put the patient into the ICU, and you're probably going to have to put them on a fentanyl drip. Why is that necessary? Well, buprenorphine binds very avidly to the narcotic receptors within the brain, and it has a ceiling effect in terms of opioid effect. It won't give them the adequate analgesia that they need, and you're going to have, if you put them up on the floor and give them a boatload of short-acting opioids, there's a chance that they'll overdose and die. You know, so you got to put them in the ICU where you put them on fentanyl drip after titration, and the reason that you got them on that drip is because there's such a narrow therapeutic index. You're monitoring them in an ICU. In other words, the level at which they get pain control and the level at which they get overdose are very close. So they have to be monitored in ICU. Do not combine benzodiazepines with opioids of any kind. This combination is the #1 cause of death in those dying of overdose. The University of Michigan protocol, you can look this up on the internet. If one of your patients is on buprenorphine, they're going to elective surgery, how do you handle it? I use the University of Michigan protocol where I stop the buprenorphine 5 days prior to surgery. I give the patient 2 to 3 Tylenol #3 QID for about 4 days just to keep the withdrawal at bay. They take their last dose the night prior to surgery, their NPO after midnight, they go to surgery, and then they respond normally thereafter, although they may have a higher than average opioid tolerance for obvious reasons. The problem of the unidentified patient. My heart goes out to y'all. My practice is Austin Addiction Medicine Associates. when you walk through the door, you're an addict. You know, I don't have to identify you. Most of the people that are going to present to you are going to be in denial. They're not going to be identified, or they're going to be purposefully obscuring that so that they can get narcotics. What are the clues to the existence of a problem patient such as that? A darkened room, okay? So when I would round at St. David's or at South Austin Medical Center on the weekend, and I walk into the room, here is a patient, usually a male, and he's hooked up to a PCA pump. The blinds are drawn. It's a beautiful day outside. The blinds are drawn. TV is off. I call his name. He doesn't arouse. I shake his arm. He doesn't arouse. I shake his body, and he comes awake, and the first thing he says is, "I'm in pain." That is a drug addict. Okay, that person is usually also asking for Phenergan, because Phenergan enhances the sedative effects of the highs of narcotics. The other thing is Benadryl. Why do they want Benadryl? Well, if you've had any experience with opiate addicts, you'll find that when they shoot and they're really getting high, they get a release of histamine and they get a pruritus, and so they tend to do this. So if you see, like I saw a kid on 6th Street the other night who he was sitting against a building, he was nodding, and he was doing this. Well, he'd shot up. That's why your patients want Benadryl. They usually have extensive knowledge about opioids and the frequency of dosing. They're timing that nurse. They have a high affinity for PCA pumps. They love stuff like that. I do not have a high affinity for PCA pumps. What to do? Shut off the PCA pump, hold all the narcotics and the benzodiazepines, come back in 40 minutes and have a heart-to-heart talk. And when you have that talk, don't shame them. Okay? Shaming and blaming someone is not what you want to do. Believe me, they get enough of that from the outside world. What you want to do is you want to try to make a difference. So you could explain to them that this is a disease. It's not a weakness of character, an inability to deal with life, case chronic wimphood, or a moral failing. It's a real live neurobiologic disease. There's treatments available. You wonder if they are seeking treatment. No, I'm not seeking treatment. Well, in that case, we're going to make you comfortable here in the hospital by giving you 30 milligrams of methadone today. I'll come around tomorrow. If you're in withdrawal, we'll give you an extra 10. And if you do have acute pain, we are going to take care of that also. In conclusion, the epidemic of non-prescription use of prescription opioids has resulted in 64,000 deaths in 2016. Medication-assisted therapy is the standard of care for the treatment of opioid dependence. It is not widely available. Look, people out there are dying faster than they did at the peak of the AIDS epidemic. And there's a big difference between the AIDS epidemic and this epidemic. We had to discover the AIDS virus, and we had to synthesize the antivirals to deal with it. We have a perfectly good treatment. We just don't implement it. Short-term detox doesn't work. Relapse rates are 95%. We need to quit sending people to detox centers. That doesn't work. Now, it works great for alcohol, all right? It works great for benzodiazepines. It works great for a lot of other things, but it doesn't work well for opioids. Nothing works better for getting the needle out of the arm than methadone or buprenorphine. Methadone's going to be better in a highly dependent drug addict because it's a full agonist, but buprenorphine's more accessible and more convenient. Buprenorphine is my drug of choice for patients who work and travel. And remember, like 70 to 80% of the patients who see me in the methadone clinic are working, all right? I don't know if, well, people who are shooting dope usually don't hold down jobs. Both drugs are useful in pregnancy, but care must be individualized. And in the words of Winston Churchill, however beautiful the strategy, you should occasionally look at the results. Thank you. Okay, I'm going to take questions. Someone want to go around and collect all the questions, or anybody brave enough to just float one? Yes, sir.
What resources are there in the community for uninsured or underfunded addicts?
I think that ATCIC, which used to be MHMR, I think that they are doing the very best with the resources that they have available, but they've got like a 3 to 6 month waiting list to get into their methadone clinic. So, we don't really have good access. I work for Maintenance and Recovery Services, which is a for-profit entity, and we are trying to incorporate Medicaid at this time so that we can begin to serve the low-income population. But we have a massive problem with access to care, and elimination of the ACA is not going to improve that.
Well, because you said that most addicts don't hold down jobs, and most people are insured through employment, so that in itself is like...
Well, you need to understand something, and that is that you see a different socioeconomic level in the methadone clinic. Now, I don't want you to think that we don't have people from all strata of society. I have a methadone patient who is getting an advanced degree in physics from UT, and I have methadone patients who are homeless. So, they come from all social strata. The other thing you have to remember is that a lot of the, only 5% of only 5% of alcoholics are Skid Row alcoholics. The other 95% hold down jobs. Okay, but it's heroin is a little bit different than alcoholism. It's a lot different, as a matter of fact, because an alcoholic can hold down a job for years if they only drink between 5 and whenever. But it's hard to do that when you're shooting heroin. Yeah. Yes, go ahead.
Well, the other question is, you alluded to it, and when you talked about the 5 risk factors of your recipe, there's obviously, there was a study with mice that if they're socialized, they're less likely to drink from the...
Yeah, what you're talking about is the book written by Johann Hari, who is an English journalist, and he went all over the world and studied all these different cultures and et cetera, et cetera. And what you're talking about is what we call the rat park. In other words, in this experiment, instead of, if you put a rat in an isolated cage with only 2 things, 1 glass of water and a glass of dope, well, they're preferentially going to do the dope. But if you put them in a rat park, which is where they have plenty of socialization with other rats, and they have little wheels to run on and all this stuff and tunnels to climb through, well, then they're perfectly happy and they don't do dope. The thing is that you are talking about that's easy to do in the laboratory, but I can tell you that it's very hard to do in real life. I have tons of patients, mostly females, that have severe post-traumatic stress disorder from childhood sexual abuse, and no amount of, that's just one contributing factor to the development of addiction. I mean, there's others, but it's very hard to, I'm strongly in favor of the idea of abolishing the conditions that give rise to this problem to begin with, but it's not that easy.
The question was going to be, for the neurobehavioral component, is there anybody or anything in town that addresses kind of all of those things, or more of those things?
Well, the general idea is, sort of a biopsychosocial model where, I think it's a really, really good idea to involve people in 12-step recovery. 12-step recovery does establish social bonds and a supportive atmosphere, which is a very, very important thing in the recovery from addiction. And methadone and buprenorphine, they do what they're supposed to do. They eliminate drug craving, they eliminate dope sickness. If you do dope, you don't get high. But they don't do anything about the underlying emotional, spiritual, mental reasons that you picked up the needle to begin with. For that, you need a program of recovery. So routinely, I facilitate 12-step involvement. But the problem in facilitating 12-step involvement is I tell them, look, when you go out there, don't advertise that you're on methadone or buprenorphine, because if people find that out, they're going to tell you right away that you need to taper off of it, and that's not a good idea because you're going to relapse. Yeah. I got a couple of questions here. What about marijuana use during withdrawal has been reported to work by patients? The thing is, there's all kinds of things that have been reported to work by patients, ayahuasca, all this stuff, marijuana, etc. And basically, if we're talking about, harmful drugs, I would have to say of the psychoactive drugs that are out there, marijuana is probably the least harmful. We do not kick people out of methadone treatment because they test positive for marijuana. In this town, marijuana is looked at as if it were, if you're serving coffee and donuts, it's coffee and donuts and marijuana, That's Austin, Texas. It's so common in this town. And that's the way addicts look at it, like it's a spice or something. So I don't, if they happen to be detoxing on their own and they want to do that, it's okay by me. Now, one thing I would tell you, though, that you really do need to be aware of is that marijuana is not innocuous. If you have a mood disorder like anxiety, depression, or bipolar, and you're smoking pot, you're going to get worse, and it'll invalidate the medication that I give you. All right.